Our area of research and project development is in promoting health and preventing disease in children with adverse childhood experiences. Our group consists of Cassie Davey, Zoe Arends-Durning, Elizabeth Cope, and Melissa Christensen. Our PICO question is, will children with a history of ACEs receiving health-promoting interventions have reduced chronic diseases compared to children not receiving interventions? The effect of adverse childhood experiences can be measured by diagnosis, number of hospital visits, as well as parents' and teachers' questionnaires and surveys. Our research shows that to help children who have experienced difficult childhood experiences, it is essential to support the children and their caregivers. Therefore, we extended our population to include both parents or guardians and the children affected by adverse childhood experiences. Interventions research to reduce the effect of ACEs on health vary widely and included multiple types of therapy, coping skills, and relaxation techniques to improve healthy choices and coping. Studies show that community and school-based interventions can be particularly successful in tailoring changes to be effective within a particular group or community. Our comparison group includes children and caregivers who have similar ACE scores but not participated in interventions. Our desired outcome is to reduce chronic diseases in those with adverse childhood experiences. We anticipate that our project may reduce some of the health-related repercussions ACEs can have on those affected. While our project itself will focus on school-aged children, we anticipate that the interventions may have lasting results throughout the lifetime. We have chosen to apply the Johns Hopkins evidence-based practice model to guide our project. This model helped us structure our clinical decision-making and evidence appraisal and is easily used for group projects. This model uses a 3-step process called PET: practice question, evidence, and translation. This process can lead to discovering best practice and improve overall clinical care. Before we begin to go into more detail on our intervention, I would like to explain a bit more about what our clinical problem involves and why we chose this particular project. The World Health Organization defines adverse childhood experiences as a frequent and intense source of stress experienced by children in their early years. Early childhood experiences are particularly significant because it is during these formative years that children develop life skills, form health-related habits, and emotional coping strategies. The Center for Disease Control, or CDC, lists the following adverse childhood experiences: emotional abuse and neglect, including excessive yelling, belittling, isolating, and lack of emotional connection; physical abuse and neglect, including hitting, slapping, kicking, and a failure to provide adequate physical care, supervision, clothing, nutrition, or adequate health care; sexual abuse, divorce in a household, having a caregiver who spends time in jail, living with a caregiver who has a substance abuse problem; significant economic difficulties affecting housing and food access; being discriminated against due to race or ethnicity; living with a caregiver who suffers from severe depression or other debilitating mental health conditions over a long period of time. Children who have 3 or more ACEs are considered at high risk for health-related repercussions. People affected by ACEs have long-term exposure to stress and elevated cortisol levels. Studies found that people with ACEs are at increased risk for health problems such as obesity, diabetes type 2, cancer, COPD, and cardiovascular disease. Additionally, ACEs are a significant contributor of poor mental health, including things like alcoholism, depression, anxiety, antisocial behaviors, and substance abuse. In addition, children with ACEs often experience social problems that can further increase their risk of disease, such as high dropout rates from high school, unemployment, and increased participation in high-risk behaviors such as drug use and criminal activity. We chose this project because we've all taken care of individuals with chronic diseases that have been exposed to adverse experiences in their childhood that directed their health behaviors. Often, we hear stories of wishing they had made different health choices, and we are excited at the idea of improving the quality of life and decreasing the risk of chronic diseases in this population. We divided our presentation into 4 domains, including mental health, physical health, health-related interventions, and prevention interventions, and searched 6 different databases. Our major findings can be summarized as the following. Adverse childhood experiences lead to chronic stress in childhood, contributing to diseases such as diabetes, cancer, and stroke, and also increase the risk of all types of mental illness. The effect of ACEs is dose proportional and at highly vulnerable times in a person's life. Early childhood interventions aimed at children and parents and include increased support of caregivers and frequent follow-up can reduce the effect of ACE. Often parents are motivated and willing to participate in health-promoting interventions, but often lack the support and resources needed to get them involved. Even short-term interventions are helpful in reducing the effect of ACEs. And creative interventions, including cognitive behavioral therapy, mindfulness, expressive writing, and skill building, were found to be helpful in preventing risky behaviors often found in those with ACEs. According to the evidence gathered on ACEs and chronic disease using PubMed, CINAHL, PsycInfo, ERIC, SAGE, and HEALWA, we searched terms including adverse childhood experiences, smoking, chronic disease, adversity, interventions, comorbidities, prevention, and mental illness, and found that children experiencing adversity may be negatively affected, and it contributes comorbidities later in life. Adversity experienced in childhood contributes to diabetes, cardiovascular disease, multiple sclerosis, and cancers, and may be dose proportional. Despite the contributing variables to ACE scores, the etiology and pathophysiology of stress contributing to negative outcomes remains the same. Stress causes an increased level of cortisol, C-reactive protein, interleukins, dysregulation of insulin, visible reduction in gray matter, and shrinking gyrus on the MRI scans, hypothesized to be from the severity of adversity. Similarly, adverse events create stress, resulting in cause and effect risky behavior that leads to cardiovascular disease, cancer, mental and physical disability, and diabetes. The severity of mental illness does not appear to be dose proportional to ACE scores, but it is a modifiable factor with possible underlying genetic components as well. ACEs can have increasingly negative effects on a person, but early intervention, even for short intervals, can have positive outcomes such as lower depression rates, reduced parental stress, and improved behaviors and decision-making in children. It was found that interventions to reduce the effect of adversity included cognitive behavioral therapy, mindfulness, EMDR, and expressive writing encouraged coping and improved resilience, which significantly reduced the risk of chronic disease and mental health. One of the studies we reviewed was a Level 4 meta-analysis of cohort studies and examined the link between ACEs and type 2 diabetes, and found that people with an increased ACE score are 32% more likely to develop diabetes. Repercussions include increased healthcare costs, comorbidities, increased symptom management, and poor overall health outcomes. The pathophysiology of the disease is hypothesized to be from stress, stimulating insulin, glucose, triglycerides, free fatty acids, DNA methylation, and inflammation markers. This research article examines the quality of brief parenting interventions in reducing behavioral problems in children in an effort to improve cost-effectiveness and lower fallout rates. Given the strong evidence presented, primary healthcare communities can be encouraged to initiate brief parenting interventions that promote improved parenting skills, thus improving their child's developmental outcomes. This study is a Level 1 systematic review of RCTs, examining interventions that could reduce the effect of ACEs that ACEs have on biological and developmental markers in children that have been found to have significant physical effect. This study of 40 randomized controlled trials evaluated the effectiveness of interventions that have addressed an array of biological markers and physical health outcomes in children and adolescents affected by adversity. The study includes 15 intervention programs run for a minimum of 6 weeks through 4.5 years at the most. Earlier interventions demonstrated better HPA access, autonomic nervous system, and central nervous system outcomes for children. Some programs showed improved outcomes with higher levels of engagement, showing that interventions that have easy access, are attractive, and culturally sensitive are more likely to have increased retention and improved outcomes. This review supports the interventions discussed and encourages continued study to improve biological health in children who have experienced early life stressors. This Level 4 cohort study sought to understand if adverse childhood experiences could increase the likelihood of being diagnosed with bipolar disorder later in life. The study concluded that there is a dose-response relationship between exposure to childhood adverse life events and later bipolar diagnosis. Parental psychopathy, defined as a psychiatric diagnosis, is a more significant risk factor than any individual ACEs, including the parental inability to work, parental imprisonment, placement in out-of-home care, parental somatic illness, and parental death before the child reaches age 15. So this suggests a genetic component as a stronger predictor of bipolar disorder than the exposure to ACEs. The researchers also note that although the effect of ACEs was statistically significant, it was modest. The framework we chose to use for this model is the disease prevention model. This is our primary prevention project, which aims to alter exposures that lead to disease. In this case, we aim to alter the reactions and behaviors that often follow exposure to ACEs to mitigate the development of chronic diseases. The school-based health centers provide primary care to at-risk children, especially low-income populations. They also offer case management and mental health services. We thought this setting would be the most effective in reaching and helping both the child and their families. A school-based healthcare center allows for the staff at schools and healthcare workers of all levels to work together to identify the children at risk and put together an integrated, evidence-based, and developmentally appropriate program that improves resilience to ACEs. In 2007, the World Health Organization reported that many of the mental health, obesity, heart disease, criminal activity, and poor literacy problems all stemmed from early childhood. It is well documented that adverse childhood experiences lead to a variety of risky behaviors and negative health outcomes. This is why early intervention is so vital in preventing comorbidities. Working with children in developmentally appropriate groups and interventions prior to and during adolescence will assist in preventing or mitigating the risky behaviors and biological stress factors that lead to chronic diseases. We chose to implement the interventions that showed the most significant improvement in health outcomes in the studies researched. These included cognitive behavioral therapy, mindfulness, coping skills, and expressive writing. Cognitive behavioral therapy identifies unhealthy and maladaptive thoughts and behaviors and assists to modifying them into healthy and productive behaviors. Mindfulness-based therapies value heightened awareness and consciousness with a non-judgmental mindset. Mindfulness has been shown to improve social, emotional, and cognitive functioning. Learned coping skills include talking with someone you trust, setting boundaries, brainstorming positive solutions, communication skills, writing a list of pros and cons, and celebrating successes. Therapeutic or expressive writing involves writing out emotions and thoughts, including negative, traumatic, or stressful events or situations. This is often completed in a specific and structured way with a specific time frame. Our next steps would be to find a satisfactory setting and team. Clinicians involved in the team may include primary care providers, registered nurses, clinical social workers, mental health therapists, psychiatrists, psychiatric mental health nurse practitioners. The members of the team would depend on the team available at the site chosen. Our evaluation will be completed by participating children meeting with a counselor one-on-one at the beginning of a school year and at the end of a school year. The evaluation should address thoughts, plans, or actions around risky behaviors, substance abuse, eating habits, activity level, as well as coping skills that each participant has learned and implemented. The comparison or control group, who are not involved in the therapeutic interventions, will also meet with the counselor one-on-one at the beginning of the school year and at the end of the school year, where the same questions will be discussed. Many articles are available to support the hypothesis of ACE scores and the link between comorbidities such as mental health, DSM-5 criteria, and chronic disease. ACE scores are negatively associated in many studies demonstrating correlation with the dose response, and it identifies contribution to poor health. Interventions such as yoga, therapeutic writing, and behavioral therapies demonstrate the ability to instill resilience and may help increase coping and alleviate symptoms of stress that contribute to both mental health and chronic disease. The synthesis of information shows a trend in articles of level 4 on the Melnick scale, demonstrating an increased need for random control studies and meta-analysis to be performed to fully understand the best interventions to decrease the risk of comorbidities in those with ACEs.